All right, so this was the slide that we are supposed to start from, and we'll start from warfarin, okay? It was initially used as a rodenticide, but now widely used in humans, all right? Because I think this drug was discovered, the drug was not discovered, but early in 1920s, they realized somewhere in Canada that some animals were dying due to bleeding. You know, the cattle were dying due to bleeding. So what they found was that they were eating spoiled hay and clover. So they tested it. What they did was the vets, they give you know, the hay, the fodder that contained spoiled clover was mixed with normal. So what they did was they separated normal from the one that was spoiled, and they gave the normal to some animals and the spoiled ones to some animals. And they found that the ones that took the spoiled one had bleeding tendencies, and many of them died as well. I think they tried the rabbits. Okay. So many people started working on it to isolate the active ingredient from there, and eventually they isolated the active ingredient, which was comodine or something like that. But warfarin came into clinical use after an incident, maybe in 1940s or 1950s, early 1950s, when someone tried to commit suicide by ingesting this rodenticide. He took many doses, but he didn't die, right? And then they realized that this could be used as an anticoagulant, and then they did some clinical trials, and they found that it was a good anticoagulant. And the first patient who used warfarin was the president of the USA. He was the first clinical patient. Just 1 minute. There is some problem today. Right. So the first patient who used warfarin was actually the president of the United States. I think that was Eisenhower. But anyway, that's how it came into clinical use. You see, there were lots of rats. They used to be in the houses and on the ships, and they used to kill them with whatever this, you know, warfarin or whatever it was known at that time. Right, so comodine, these are warfarin tablets that came into use in 1950s, right? And the name warfarin, this also has got a story behind it. It's, you know, it's this WARF stands for this Wisconsin something research federation or something. So this word WARF actually comes from the people who did research on this, and this arin was added because it belonged to the coumarin group, okay? Anyway, that was the history. So warfarin therapy is monitored by international normalized ratio, because when you give an anticoagulant, the bleeding time is going to increase. So you compare that to the normal bleeding time, and it should be something like 2.5 to 3 times or 2 to 3 times longer than the normal bleeding time. That is what INR is. The goal of therapy is to achieve an INR of 2 to 3 for mechanical heart valves, and INR of 2.5 to 3.5 is recommended, all right? So warfarin has a narrow therapeutic index. So that is why you have to continually monitor. If you go above this INR, then there is a risk of bleeding. And the bleeding could be anywhere. It could be in urine, it could be in the cranium, it could be in the GI, all right? So it has a narrow therapeutic index, and that is why we have to monitor this, and we have to bring it back if it goes above that, all right? So there is someone in the background, so I'll mute everyone. I hope it's not a question for me. If there's any question for me, you can write it down on the chat and I'll read it. Right, so Frequent monitoring is strongly recommended. Coumarin anticoagulants antagonize the cofactor functions of vitamin K, and I'll show that to you in the next slide, because there are certain clotting factors 2, 7, 9, and 10 that are dependent upon vitamin K for their post-translational modification, right? So here it is, vitamin K dependent coagulation factor. So this is the pathway that I showed you yesterday, and this is the intrinsic pathway. So factor 2, which is prothrombin, factor 10, factor 7, and factor 9, 2, 7, 9, and 10. These are known as vitamin K dependent clotting factors. All right, so it is the post-translational modification that I'll explain to you in this slide. These factors are synthesized by the liver, but they need some post-translational modification, which is important for their clotting function, okay? So vitamin K causes carboxylation of glutamic acid residues on these factors. Now, can anybody tell me, it says carboxylation. What is a carboxyl group? Please quickly tell me, just 4 alphabets, carboxyl group. That's a little bit of biochemistry, very easy. And I've got one answer, which is COOH. That is wonderful. So now this is important because when it is in solution, COOH is going to lose the H and it will become negatively charged, and then it will bind the calcium. We need carboxyl groups to bind calcium ions, and binding of calcium is necessary for clotting. But the problem is, in the process of carboxylation of these glutamic acid residues, vitamin K is converted to vitamin K epoxide, and we have to bring it back into vitamin K state. Okay, so the enzyme that does that is vitamin K epoxide reductase, right? So through this pathway, we return it to its original shape, and it can do its work of the post-translational modification of factor 2, 7, 9, and 10, right? So what does warfarin do? Warfarin sorts of inactivates this. Oh, there is a question, where does post-translational modification occur? That is an interesting question. It is not pharmacology, that is actually cell biology. Now, but I'll tell you a little bit, there are 2 types of proteins that are made by the cells. One is that are supposed to be excreted by the cell, and one type of protein that have to remain inside the cell, all right? At any given time, the cells have got 10,000 different types of proteins in them, all right? So the proteins that are supposed to be excreted by the cells have got a signal peptide that takes them to the endoplasmic reticulum. And as the ribosomes elongate the polypeptide chain, they go into the endoplasmic reticulum, and there is a very say busy or frequent connection between endoplasmic reticulum and the Golgi apparatus, right? So some post-translational modification occurs inside the endoplasmic reticulum. Some glucose moieties are added over there, but most of the post-translational modification occurs in the Golgi, right? And from the Golgi, then again, we have vesicles that break off and they take them to the cell membrane, the plasma membrane, and they go out by exocytosis, right? So is that clear? Well, that's the process. And if we have to do more details of to which amino acid, which glucose is attached, or whatever, that is beyond the scope of this lecture. But that was quickly what post-translational modification is. So the answer to your question is post-translational modification a little bit occurs in the endoplasmic reticulum, but mainly it is in the Golgi apparatus. Right, so what does warfarin do? It sorts of inactivates vitamin K epoxide reductase, inhibits vitamin K epoxide reductase enzyme. This enzyme is needed to convert vitamin K epoxide back to vitamin K, right? So if you block this, obviously we are not going to get the carboxylation of these clotting factors, and the activity or the efficiency of these clotting factors will be reduced by 40%. Warfarin reduces the activity of clotting factors to less than 40%. And warfarin takes 72 to 96 hours to become fully effective, right? So that is why, if you have to give anticoagulation post-surgically, for example, yesterday we said that, let us suppose that a patient is undergoing hip replacements, hip joint replacement surgery, or a knee joint replacement surgery. He or she will not be able to move his leg for quite some time. So he has to be given anticoagulation to prevent deep vein thrombosis. But if you start giving him warfarin, it's going to take 3 to 4 or 5 days to have it fully effective. So what we do is that we start with low molecular weight heparin and warfarin at the same time, or you can sometimes start warfarin the next day. So we give both these drugs together for at least 5 days, or until we reach our desired INR. And then we stop the other drug like the low molecular weight heparin, and we keep going with warfarin. And this is known as bridging for warfarin, okay? You might come across this term bridging when you go to your clinics, okay? Right. So addition of vitamin K reverses the effect of warfarin in about 24 to 48 hours. And you do the same bridging before the surgery as well. You have to give some short-acting anticoagulant like low molecular weight heparin. Okay, let me admit someone. Right. So the thing is that you do bridging with a short-acting anticoagulant. Now, clinical use, prevention of and treatment of deep vein thrombosis and pulmonary embolism. So you must have noticed that all of these anticoagulants have got more or less the same clinical uses. Prevention of stroke, it depends upon the urgency of the use or the rapidity of the effect you want, or the state of the patient, which one or in what way you are going to use it, okay? Prevention of stroke in atrial fibrillation. And why do we get a risk of stroke in atrial fibrillation? Can someone tell me? Why do we get a stroke in atrial fibrillation? Okay. There is a clot risk, yes, because when the atria are fibrillating, they are not contracting. So there will be a stasis of blood, especially in the left atrial appendage. Left atrial appendage is a sort of an outpouching of the left atrium. So the blood will collect there, and there is a risk that it will clot. And when the atria start beating again, then a small fragment can break away and it can go to the brain, all right? So prevention of stroke in atrial fibrillation, and then prevention of thromboembolism after surgical procedures, same that we have done for everything. So warfarin is used in myocardial infarction, pulmonary embolism, atrial fibrillation, deep vein thrombosis, congestive heart disease, and prevention of stroke, okay? Right. Then for patients with prosthetic heart valves, so we have got two types of prosthetic heart valves. One comes from the pig or the cows. It has got certain advantages. We don't need anticoagulation for this one, but for the prosthetic one, we need a lifelong anticoagulation. But the advantage is that this has got a longer life. It stays there for more than 20 years, and this one lasts just 8 to 10 years, all right? So these were a few indications, and now we go back to the questions, all right? And the question is, a 30-year-old woman presented to her family physician complaining of black tarry stools. And now you have to read it yourselves. All right. So any answer? I got two answers, and which is D, which is correct. What I want to convey through this clinical vignette is that that sometimes there could be a problem of overdosage, right? So these are the signs of overdosage of warfarin, subconjunctival hemorrhage and bruises or whatever. All right, black tarry stools, which shows GI bleeding, okay? So the correct answer, of course, is warfarin. Streptokinase mechanism of action. We are going to come to that in a little while. It cleaves plasminogen to form plasmin. What does plasmin do, by the way? Can anyone tell me what does plasmin do? Why are we converting plasminogen to plasmin? So plasmin will, let me break down the fibrin plots. Very good, that is right. And aspirin, you already know the mechanism of action. It is an adjunct drug in prosthetic valves with warfarin. So many times in certain situations, we give aspirin with warfarin because warfarin is an anticoagulant. It is blocking the coagulation pathway. We still need to block the platelets as well. So that is why we are giving aspirin with that. Heparin, we have already seen that antithrombin mediated inhibition of thrombin. And then aminocaproic acid that we will do today inhibits plasminogen activation. So you see, this is activation of plasminogen, and this is inhibition of plasminogen activation. So streptokinase and aminocaproic acid, they have got opposite actions. Bivalirudine, you have already seen that it is direct thrombin inhibitor. So the answer is most likely warfarin overdose, okay? The required INR must have shot above 3.4. If it goes to, 3.5, if it goes to 4 or above that, then we get risk of bleeding, okay? Right, pharmacokinetics, it's given orally predominantly. In some rare situations, it could be given intravenously as well. Warfarin is rapidly absorbed from GIT and bioavailability is 100%, all right? And a plasma bind, this is an important point. Plasma binding is 99%. High protein binding prevents entry into CSF. And any drug that is protein bound, that is biologically unavailable because it is protein bound. It cannot act, right? Now this 99%, let's see what the next thing is. Drug with high affinity for plasma proteins such as sulfonamides can displace warfarin from proteins and cause toxicity, which is bleeding. Now let us suppose that just 1% of albumin, 1% of warfarin is displaced, right? So now instead of 1% in plasma, it is 2%, which means we have doubled the dose of warfarin. You see what I mean? Just displacement of 1% of warfarin will double its dose, and that is going to lead to serious consequences like bleeding, okay? So this is an important point that you must remember. Warfarin readily crosses placenta and it is fetotoxic. Half-life is variable due to genetic variations in CYP450 enzymes. So, but on average, it is 40 hours, which is pretty good. We don't have to give many doses in one day. Metabolism is through CYP450 isoenzymes. It's a big family of enzymes, and it is glucuronidation, which is a phase 2 metabolism, which makes the drug soluble in water, okay? Excretion of metabolites is through the kidneys, and there is a long list of drug interactions. And this is something I want to show you, that different doses of warfarin have got different color coding. And the color coding is different in the USA and different in UK. So see, when you see a pink box, it's 1 milligram, lavender is 2 milligram, green, tan, blue, peach, teal, so different strengths of the tablet with different colors, okay? Warfarin drug interactions, as we noted in the last slide. You see induction inhibition of so many enzymes. It is metabolized by so many different types of enzyme, 2C9, 2C19, 2C8, and these enzymes have got genetic polymorphisms. They could be induced by certain drugs. They could be inhibited by other drugs, okay? So these things, stimulation of metabolism, alcohol ingestion, it induces the CYP450 enzyme system, right? A P450 enzyme system. So that will increase the metabolism. Barbiturates, dicloxacillin, rifampicin, phenytoin, carbamazepine, so many drugs, they induce this and they attenuate the anticoagulant activity of warfarin. And we have got then inhibition of the metabolism. Chronic and acute have got opposite effects. Acute alcohol intoxication, amiodarone, fluconazole, metronidazole, sulfamethoxazole, trimethoprim, they inhibit that, okay? And potentiation of anticoagulation. And, sometimes we give aspirin that will further potentiate the anticoagulant effect of warfarin, okay? Right. So adverse effects, there is a black box warning by FDA, highly potent anticoagulant, serious bleeding results from overdosage. Do not use or dispense before reading directions, and warnings in accompanying product information. That is the responsibility of the doctors and the pharmacists and the nurses as well. The principal adverse effect of warfarin is hemorrhage. Frequent INR monitoring and dose adjustment is essential. And fortunately, we have got this piece of equipment that can measure the INR for the patients who are on warfarin therapy. Bleeding is managed according to severity of hemorrhage with either vitamin K. We can give it orally, we can give it IV. It is known as vitamin K1 injection. That's the name, pharmacological name over there. Whole blood, fresh frozen plasma, plasma concentrates of clotting factors are also used, okay? This is a rare complication, which is skin necrosis. Warfarin is teratogenic, contraindicated in pregnancy. We can give heparin or unfractionated heparin, that is the safest, or even low molecular weight heparin will do, although it is 1/3 the size of unfractionated heparin, all right? All right, let's read this question. A 55-year-old man complained to his physician of stools stained with bright red blood and pink urine. So this patient has got GI bleed, and he has got bleeding in with his what you call hematuria, right? 2 weeks earlier, the man had started a treatment with warfarin for recurrent deep vein thrombosis, all right? On physical examination, the patient appeared pale and diaphoretic. Oh my God, he's pale, all right? And this obviously means he has lost quite a bit of blood, all right? Vital signs were blood pressure 85/55, which is pretty low. Heart rate 105, respirations 20 per minute, and an appropriate therapy was started. All right. So, just one clinical question. What do you call a low blood pressure? Well, previously, there are actually two definitions, okay? And one is that, the patient has signs and symptoms of low blood pressure. For example, he might have dizziness, he might have lightheadedness, right? And the other clinical definition is if there is a fall of more than 30 mm of mercury from the baseline. That's my daughter Verda coming on the camera. All right. So if there is a fall of more than 30 mm from the baselines, particularly of the systolic, that too we call a low blood pressure. All right. So which of the following drugs was most likely administered intravenously to the patient? And I think it should be easy for you to answer. All right, so the two answers are A and vitamin K. Now, actually, that is the wrong answer. I'll tell you why. I mean, the thing is, see, it is a sort of an emergency. You see, his stools are stained with blood, his blood pressure is low, he is pale, he has lost a lot of blood, and you must act quickly. If you give vitamin K, it is going to take at least to synthesize new vitamin K dependent clotting factors about 24 hours at the minimum, right? So that's a bit late. You must act very quickly over here. And I've got another answer, which is from Saima, and that is fresh frozen plasma, because it has got all the clotting factors readily available. So the correct answer is fresh frozen plasma. So it is a life-threatening GI bleeding from warfarin overdose. He has got hypotension and tachypnea over here. Treatment, in addition to this, you'll also give impact RBCs, he's pale, fresh frozen plasma, and intravenous K1 as well. That is not a wrong answer, but actually you should take more drastic measures at this point, okay? So emergent reversal of elevated INR. Note the response to IV vitamin K is slow, at least 24 hours, okay? Another question, it's a 62-year-old woman complained to her physician of nosebleeds and bloodshot eyes. The woman had been receiving warfarin for 1 month because of deep vein thrombosis. 4 days earlier, she had started treatment with erythromycin for acute pharyngitis. Which of the following drug-induced changes was most likely responsible for the patient's symptoms? All right. Jamal says that it is A, but unfortunately, that is not the mechanism of erythromycin. Erythromycin does not do anything to the clotting factors. It has got no relationship with the synthesis of clotting factors. Any other answer? B is the correct answer. Yes, that is right. Erythromycin-induced inhibition of warfarin metabolism. That is the right answer in this question. So this was just for reinforcement of your learning. There are certain things that you learn through these clinical vignettes as well. Right, now we go on to the next part of the lecture, which is on thrombolytics. We have got Alteplase, Riteplase, Tranexamic, and streptokinase, which we said is not very commonly used because it is antigenic. It leads to the formation of antibodies. Urokinase, we don't use it very commonly because we have got better options. And the last one is this that will go after we complete this one, okay? So this is a slide that I've shown you previously, and I am showing you a clot over here. So whenever a clot is formed, there are other mechanisms that come into play, and one of them is this tissue plasminogen activator, which normally is inactive because it is inhibited by a plasmine activator inhibitor, right? So when we have a clot, this inhibition is removed, right? And this tissue plasminogen activator, it will convert plasminogen to plasmin, okay? This combination. And plasmin, as someone said previously, is going to break down the fibrils, right? And what we get is dissolution of the clot, and we get fibrin degradation products. And one of them, is D-dimer. And we use this D-dimer test to see that if any clotting is going on in the body or not, to diagnose deep vein thrombosis or something like that, okay? And then we also have got plasmin inhibitor, right? So, it is a balancing act. The body is trying to balance, and it is obviously very well balanced in normal physiological conditions, okay, which is known as hemostasis. Right. So just a word on this D-dimer test because it is so common. I've taken this from Wikipedia. So what happens is that fibrinogen will be converted to fibrin by thrombin. And fibrin is going to form a mesh in which it will trap the platelets and the RBCs, and it's going to form a clot. And then factor 13 will cause cross-linkings. And when we have got plasmin, this will be broken down. This will be cleaved, and we get D-dimers, which is the smallest fragment of all these fibrin degradation products. Okay, so this was a quick review of the D-dimer test. And we have got a question over here. It's a 71-year-old woman who underwent hip replacement surgery, was discharged from the hospital with an appropriate post-discharge therapy that included daily subcutaneous injection of regular heparin. All right. So which test? The patient is on heparin, and the answer is, one answer is B, let's say platelet count is a very good answer. Yes, that is correct. E is not correct because heparin does not cause fibrinolysis. You know, it is not, heparin is not a fibrinolytic or a thrombolytic drug, okay? Heparin just stops the formation of the clot. It cannot dissolve the clot. So with heparin, you know, we must do the platelet count, which is important because of the heparin-induced thrombocytopenia that we get, okay? So 1 to 5% of patients using standard unfractionated heparin develop thrombocytopenia due to antibodies to a complex of heparin and platelet factors. So this factor leads to the formation of antibodies, and these antibodies, they activate they activate the platelets. And when they activate the platelets, we will get thrombocytopenia, and we will also get a lot of platelet plugs, okay? So that is what is known as heparin-induced thrombocytopenia. Clinical features of thrombocytopenia, it occurs after 5 to 10 days of ongoing heparin use, a 50% fall in the platelet count. So we must have taken a baseline, or we must always take a lot of baseline measurements. That's very important. Resolution of thrombocytopenia 5 to 10 days after cessation of heparin, and a high risk of thrombosis is noted in 30 to 75% of patients because of the activation of the platelets due to this antibody. All right. Right. So thrombolytic drugs, all thrombolytic drugs act directly or indirectly to convert plasminogen to plasmin. Okay. So we have got Alteplase, we have got streptokinase, and we have got urokinase. And previously I said that streptokinase is highly antigenic, right? So plasmin cleaves fibrin, thus dissolving the thrombus that we saw in the previous slide. And that will lead to, all of these are activated, converting plasminogen to plasmin, okay? And we get fibrin degradation products. The drugs are more effective in dissolving clots when initiated early in the course of clot formation. As the clot dissolves, there is a tendency of formation of local thrombi and platelet aggregation. And we have got certain strategies, like we can give aspirin and we can give heparin as well. All right. So that was the mechanism of action, and the therapeutic uses. It's used for deep vein thrombosis, pulmonary embolism, myocardial infarction, but that is not the preferred therapy in myocardial infarction. I must mention that. I think I must have written it over here, because the preferred therapy after myocardial infarction is PCI, percutaneous coronary intervention, right? We must pass a catheter, reach the blocked vessel, and recanalize it. Although you can, it's, if you have to give, for example, I mean, there is a some situation in which you cannot do PCI. It is better to give this just at the place where the clot has formed, okay? Sometimes it is not possible to recanalize the artery because it's a very small artery. You cannot put a stent over there. It is a very proximal artery in the heart, and it is so small that you cannot push a stent in there. So maybe under those situations, you can deliver the drug locally to the clot, but you have to pass a catheter. Use of thrombolytic agents is becoming less frequent because they cause bleeding. So our treatment of choice is PCI. But in case, after the myocardial infarction, the first hour is known as the golden hour. If you give treatment during that hour, especially PCI, then you will salvage a lot of heart tissue and the heart muscle. All right. But if the facility does not exist or the hospital that has the facilities too far away, then you can use these thrombolytic drugs. For STEMI, intracoronary delivery is more reliable in achieving thrombolysis, if that is possible. PCI is preferred over pharmacological restoration of reperfusion. However, on many occasions, PCI cannot be offered within the salvage time, okay? Thus, fibrinolytics are administered IV. So up to, you can say 120 minutes, you can do a PCI, you can salvage or at least some of the cardiac muscle, right? So they are given intravenously. Fibrinolysis is used in ischemic stroke, right? Right, another question. A 42-year-old woman suffering from the systemic lupus erythematosus presented to the clinic with a moderate substernal non-radiating pain. All right, there's some. Okay, so let us see whether you can answer this question or not. Now we are asking about a drug that is contraindicated. Although in the exams, you will not get this highlighted or, keywords, you will not get in the exams, but let us see. All right, so it is a moderate substernal pain. It is non-radiating, right? And the pain is worse during inspiration when lying flat and is relieved when the patient leans forward, right? So, this thing, worse with inspiration, that is not characteristic of ischemic heart pain, right? And leaning forward, that is typical of pericarditis. And friction rub is diagnostic for acute pericarditis, right? So in this case, you're not going to give a fibrinolytic drug, which you might give if the patient has got a myocardial infarction, okay? So the distinction between myocardial infarction and acute pericarditis is crucial. If pericarditis is misdiagnosed as MI, thrombolytic drugs may cause pericardial hemorrhage and cardiac tamponade. Usually, pericardial pain can be distinguished from the ischemic coronary pain because the latter is not aggravated by chest motion or body position, right? This ischemic heart pain. A precordial friction rub is diagnostic, right? So adverse effects, in big font is hemorrhage. Absolute contraindications to these drugs are prior intracranial hemorrhages, known structural cerebral vascular lesions like aneurysms, okay, intracellular cranial neoplasm, active bleeding, severe uncontrolled hypertension. All right, all of these are high risk in themselves for a bleeding episode. Alteplase is a serine protease obtained by recombinant DNA technology. Most of these Alteplase, Tranexamic, and what is the third one? Retablase. They are all produced by recombinant DNA technology. Alteplase selectively acts on the thrombus. That is a good thing. It has high affinity for fibrin-bound plasminogen in a thrombus. So it is selective and low affinity for free plasminogen circulating in plasma. Therapeutic uses, again, ST segment elevation, myocardial infarction, pulmonary embolism, acute ischemic stroke, right? That you have to be careful, not hemorrhagic stroke. Obviously, you'll never give that in a hemorrhagic stroke, okay? Which is not the most common type of stroke. Half-life is short, 5 to 30 minutes. 10% of total dose is given by an IV push, and then the rest you administer slowly over 60 minutes. And angioedema is a risk, particularly when combined with ACE inhibitors, right? And that is what angioedema is: swelling of the lips and the face and the tongue. And the most dangerous thing about angioedema is this edema of the larynx, swelling of the larynx, because that can obstruct the breathing of the person. So this is a preparation which is for IV infusion. And this is another preparation by Genentech, which makes the most expensive medicines. And this is a very common use, right? For use in central venous access devices. You know, sometimes you have to keep the IV line for a long time. Can you give me any example when you have to have the IV line for a long time? I'll give you a couple of examples that come to my mind. Maybe I have them in some slide. This port A catheter, which is placed in the subclavian vein for giving anti-cancer drugs, you know, that is placed for a long time. Very good. TPN, yes, total parenteral nutrition. That is an important one. Another one that comes to my mind is this fistula for hemodialysis, you know, for dialysis patients. So for these purposes, it is used very commonly, and this is what it shows. It, you know, the blocked catheters can be opened with this drug, okay? Cath flow activase is the standard of care for treatment of thrombotically occluded catheters as assessed by the ability to withdraw the blood, all right? So, you know, if you, before giving an injection, you withdraw the blood to see whether it's pate open or not, okay? And if the blood does not come into the syringe, that means there is a problem. All right, so Alteplase and Tranexamic. Alteplase is genetically engineered derivative of TPA. Tranexamic is also recombinant TPA with longer half-life. It has greater binding affinity for fibrin than Alteplase. Therapeutic uses: STEMI, DVT, pulmonary embolism. Tranexamic is STEMI. Half-life: both drugs have longer half-lives, therefore may be administered as IV bolus. And you have got these preparations of Tranexamic, which is for intravenous use, and Alteplase, which is I'm not sure whether it is subcutaneous or is it written. Can someone see? It's not written what it is. All right. Anyway, whatever, it should be IV. It says IV. All right. Now, this drug is no longer available in the USA. It is, this is antigenic. So immunogenic, I mean. So we'll just quickly go through this. We'll not, you see, streptokinase is antigenicity is very high, right? And fibrin specificity is low. So these are undesirable characteristics. Half-life is long, that's a good thing, but we don't use it. Okay, urokinase, it is produced in the body by the kidneys, so it is not antigenic. Okay, medicinal urokinase is obtained from cultures of human neonatal kidney cells, but it's not very commonly used because these Alteplase, Tranexamic, Alteplase, they are better drugs than this. It has low antigenicity, cleaves plasminogen to plasmin, that is the mechanism of action, and therapeutic uses are same as pulmonary embolism, catheters, and yes, here I have mentioned dialysis, fistula, or port A catheter, or like someone said, TPN, okay? Off-label use is myocardial infarction, deep vein thrombosis, arterial thrombi of any kind. Alteplase is preferred, or urokinase, because of better benefit to risk ratio, right? So again, this is for intravenous use, and this is the brand name which is given on this Swiss knife as well. Right, so now we go to the last part of this lecture, and we are almost at the end of our allocated time as well. So we have got aminocaproic acid, tranexamic acid, protamine sulfate for heparin, and vitamin K for warfarin, and these two are for thrombolytic drugs. So indications for use: any condition leading to clinically significant bleeding. Now, this is the opposite thing we are doing. Now we have got some bleeding tendencies. Previously, we were treating clotting. Now we are treating bleeding, okay? Clotting factor deficiencies like hemophilia, fibrinolytic states after surgery or trauma as a result of overwhelming activation of tissue factor, overdosage of anticoagulant therapy, which is the most common use. Treatment with blood product carries the risk of transferring viral infections. That's an important point to note. And a quick word about these human blood products, right? From the whole blood these days, we get a lot of things. We process it. We get packed RBCs. To increase the amount of RBCs after trauma or surgery. When the patient is not volume deficient, he's RBC deficient, then we can give packed RBCs, and we can keep the plasma for some other purposes. Storage time is 42 days in refrigerator and 10 years in freezer. So you see, packed, you just spin it and the RBCs will go down. And you spin it very slowly, and after some time, the RBCs will go down and you will separate them. Then we have got fresh frozen plasma to correct a deficiency in coagulation factors or to treat shock due to plasma loss from burns or massive bleeding, right? It has got 1 year of life in the freezer. Then we have got these cryoprecipitate to treat fibrinogen deficiencies, again storages, 1 year in freezer. And we have got platelets as well to treat or prevent bleeding due to low platelet levels, due to any hemorrhagic viral disease or something, to correct functional platelet problems. Storage is 5 days at room temperature, so that is a very short time. All right, so aminocaproic acid and tranexamic acid, both agents are synthetic, orally active, excreted in urine, and inhibit plasminogen activation. Okay, so it will prevent the dissolution of the clot. They will preserve the clot, okay? Tranexamic acid, 10 times more potent than aminocaproic acid. A potential side effect is intravascular thrombosis, okay? And these are some of the preparations. This is injection. This comes as tablet as well. And this one also comes as tablet. So this is both IV, both of them are IV as well as oral preparations, right? Protamine sulfate for heparin antidote, okay? This protein is derived from fish sperms or testes and is it is high in arginine content, arginine, as you know, that arginine is one of the positively charged amino acids along with histamine. And there is one more, I think lysine, yes. Arginine, lysine, and histidine are positively charged amino acid, right? So the positively charged protamine interacts with negatively charged heparin, forming a stable complex without anticoagulant activity. Adverse effects are hypersensitivity, dyspnea, flushing, and hypotension. And these are the things, in pharmacology that you have to memorize, unfortunately. And I guess this should be the last slide of the day. It is administered orally, subcutaneously, or slow IV injection. Subcutaneous route is the least effective. Response time is about 24 hours, okay? And there you see that it has the ability to replenish the vitamin K that has been inactivated by warfarin, okay? And these are the preparations that we have, IV, and these are the tablets over here. And I think that is all for today. And if you have any question, you can ask me now. All right, then thank you very much for attending this lecture. We have covered quite a lot of ground in cardiovascular diseases. I think we have done heart failure, we have done hypertension, we have done anti-anginal drugs, we have done anticoagulants. I think next what we will do is we will do lipid-lowering drugs, although diuretics also come under cardiovascular drugs, right? We have antiarrhythmics as well, but we'll make a decision later on, right? So thank you very much, all of you. And I will see you all next time.